A lot of people believe that peptic ulcer disease is caused by going hungry or skipping meals. Is that actually true? Hi everyone, I am Beatrice. In this video, I will break down the true cause of peptic ulcer disease, including one sneaky bacteria you may have never heard about, or medications like NSAID, the role they play in peptic ulcer disease, and also symptoms of ulcer that you should never ignore, how ulcers are diagnosed and treated. And before the end of this video, I will also review some NCLEX-style questions that will test your knowledge on this topic. So if you are ready for today's lecture, let's begin. Peptic ulcer disease is the presence of ulcer in the lining of the stomach and the duodenal, which is the first part of the intestine. And in rare cases, the esophagus may be involved. And this is due to alteration in the mucosal barrier. Under healthy conditions, the stomach protects itself from its own acid that it secretes, and that acid is hydrochloric acid, and also from its own enzyme, which is pepsin. Now, it does this through some mechanism. One of them is mucus secretion. So it secretes mucus, which will act as a physical barrier. It kind of coats that lining to prevent it from being eroded by acid and those enzymes. And also, it also secretes bicarbonate. The gastric cells of the stomach secrete bicarbonate. Bicarbonate is a base that will help to buffer that acid so that the effect is not fed in the stomach or in the duodenum. Another mechanism it uses is prostaglandin. So prostaglandin is secreted by different cells of the body. It's a hormone-like lipid compound. Now, when it's secreted for the gastrointestinal tract, it is there to help increase blood flow. It increases mucus secretion. It distributes bicarbonate. So we know that bicarbonate is a buffer that will help buffer that acid. So when it's able to help spread or distribute that bicarbonate, the effect will be decreased acid secretion. Now, all these mechanisms together, including tight epithelial junction, form what we call the mucosal barrier. So it helps to protect the mucosal lining of the stomach, the intestine, the GI tract as a whole. Now, and also this mucosal barrier helps to prevent the attachment of the bacteria called Helicobacter pylori. We know that usually, even before you eat, hydrochloric acid is secreted by the parietal cells of the stomach. It's secreted to act on the food. It digests the food as soon as the food comes, and even more is secreted as you eat. And also, it helps to kill bacteria because as you are eating, you may ingest some bacteria. So it's another purpose of that hydrochloric acid being secreted while the stomach is always acidic, is to digest those microbes, all those microorganisms, bacteria and the rest, so that it doesn't harm your body. And also, it's there to also activate the production of pepsin, which will help in the digestion of proteins. But in a situation where there's disruption in this mucosal barrier, what will happen is that the acid that is secreted and the pepsin will begin to digest the lining of the stomach, and that will lead to that ulceration, that formation of ulcer. Now, looking at the pathophysiology of peptic ulcer disease, one thing you have to know that before this ulcer will develop, there have to be a precipitating cause. Something had to trigger this whole thing, the digestion of those lining of the stomach and the gut. The first thing is H. pylori. So if somebody is infected with Helicobacter pylori, it's a bacteria, it's going to attach to that mucosal barrier, penetrate, and begin to cause problem. It's going to decrease bicarbonate secretion, and it's going to lead to break down the mucosal barrier, and the erosion will begin to occur. The other word is NSAID. That's another most common cause of peptic ulcer disease. Medication like ibuprofen what it does. The role of NSAID in this is that it inhibits the synthesis of prostaglandin. Remember, I mentioned that prostaglandin does a lot of role in reducing acid secretion by distributing bicarbonate and increasing blood flow. So when you give NSAID, it goes and attack or reduce the synthesis of prostaglandin, meaning there's nothing promoting bicarbonate secretion or increased mucus production. So it automatically leads to, it makes the mucosal barrier to be vulnerable to damages. Then other one can be smoking. It can further destroy the epithelial cells, the excessive use of alcohol, and then even stress. Then things like spicy food or gas-forming food, those ones are just like trigger. They are not really the cause. They can worsen symptoms. Another cause of peptic ulcer disease is a digestive disorder, though rare. It's called Zollinger-Ellison syndrome. So when somebody has this disorder, there is a presence of gastric tumor what we call gastrinoma. When it's there, it causes excess gastrin that will lead to excessive gastric acid secretion, and that can further erode the stomach and predispose the person to ulceration. Now, this will make me to mention the role of hunger. So, hunger itself does not really cause peptic ulcer disease. It only worsens that ulcer pain, especially in duodenal ulcer, because it's when the person has not eaten, the pain gets worse. So, what happens is that normally I mentioned it before that when you are hungry or when you've not eaten, an empty stomach is going to stimulate the production of hydrochloric acid, and that hydrochloric acid is produced in anticipation for food, so that once the food arrives, it begin to digest the food and begin to destroy the bacteria that may come along with the food. So in other words, if you are healthy, your stomach lining is healthy, there's no breakage in that or destruction or damage to that mucosal barrier. Even if you are hungry, you are not supposed to develop ulcer in the first place if those other precipitating factors are not there, if the mucosal barrier is not broken. Now, with these precipitating factors, the next thing I mentioned is going to be destruction of the mucosal cells and loss of mucosal barrier. That's what we've established. And also, H. pylori itself causes even hypersecretion of acid and pepsin, including the Zollinger-Ellison syndrome. So, with any of these disruption, there's going to also be hypersecretion of acid and pepsin, and the overall outcome will be ulceration of the stomach lining, the duodenal lining. Now, let's look at the signs and symptoms of peptic ulcer disease. One of them is dyspepsia, that's indigestion. Another one could be heartburn, epigastric pain, nausea, vomiting, and then we have bleeding. So this bleeding can be in form of vomiting of blood, which is what we call hematemesis. And also, there could be black tarry stool, which is what we call melena. So depending on the ulcer that is affected, most times gastric ulcers, because it's more higher in the GI tract, the patient may experience hematemesis. While for duodenal ulcer, it's more like down. So the patient may stool, when they pass stool, they may see blood in what we call melena. It's going to be dark and tarry because of the digestion. Those blood have been digested by the gut. Now, let's look at the complication of peptic ulcer disease if it is not properly treated. One of them is perforation. So perforation, that's to do with when the ulcer penetrates through the entire walls of the lining of the GI tract. So it can pass through the entire lining, like the mucosa, the submucosa, the muscularis, and even the serosa. So it can cause perforation, creating a hole. And the second one is peritonitis. Now, from perforation, it can lead to peritonitis, which is inflammation of the peritoneal cavity. We know that peritoneal cavity is sterile, but when the hole is created, gastric and duodenal content can leak into that sterile peritoneal cavity and cause infection. So the patient is also at risk of septicemia. Another one is gastric applet obstruction. So with repeated chronic inflammation, it can cause scarring, especially around the pyloric region, and then disrupt the flow of food or passage of food into the duodenum. Then hemorrhage, of course, I mentioned is one of the signs to bleeding. Then another one, in rare cases, the patient could develop gastric cancer. Let's look at how peptic ulcer is diagnosed. One of them is through barium swallow. So a patient is given barium sulfate to drink. When they drink it, an X-ray is taken to visualize and to see those organs, the structures in the stomach, to see the presence of that ulcer. Another one is endoscopy. So they may pass a tube with a camera to visualize the gastrointestinal tract. And then there's what we call urea breath test. So this urea breath test is used especially to diagnose Helicobacter pylori. So when the patient is given, it can be in form of tablet, capsule, or solution. When the patient is given this urea, usually if the patient takes it and the patient is infected with H. pylori, the H. pylori there is going to convert that or break down the urea into ammonia and carbon dioxide. So when the patient breathes out, they collect the breath and test for presence of carbon dioxide. If the carbon dioxide is high, that's a confirmatory test that the patient is infected with H. pylori. Then another one is blood stool test, to check for the presence of blood in the stool. And then biopsy, CT scan with contrast can be done to visualize also the stomach, the intestine, and to see the location of the ulcer. For the biopsy, they can collect a sample, especially during the endoscopy. They can take a sample from the stomach or the duodenum and test for, especially most time, to rule out gastric cancer. Now, let's look at the difference between gastric and duodenal ulcer, because these are the two most common peptic ulcer disease. The first one is that for gastric ulcer, the pain is worsened with food. So when the patient has gastric ulcer, within 1 hour of eating, they begin to feel pain. But for duodenal ulcer, the pain is actually relieved with food. So within 3 hours or 4 hours of eating, that's when they begin to feel pain, showing that the stomach is empty again. So once they eat, the pain is relieved. Another thing is weight loss. There's weight loss in gastric ulcer, and that's that fear of eating, because once they eat, the pain comes. So most times they are the one that experience weight loss. But for duodenal ulcer, they will experience normal weight because they even eat to kind of combat that pain. Then, in severe cases for gastric ulcer, they are prone to hematemesis, where they can vomit blood. But for duodenal ulcer, they can have what we call malaria, which is black tarry stool. Then another thing is that for gastric ulcer, the acid production may be normal or decreased, but in duodenal ulcer, there's increased acid production, especially because for duodenal ulcer, they are more predisposed, or they are more caused by H. pylori, and H. pylori also causes increased acid secretion. So the gastric ulcer is mostly associated with the use of NSAIDs, but for duodenal ulcer, I mentioned earlier, H. pylori is a major cause of duodenal ulcer. Let's look at how to manage peptic ulcer disease, including nursing intervention. So the first thing is medication. So for peptic ulcer disease, we can't do without medication. So they combine a lot of medication. Most times they give them antacid. I'll look at antacid in another video. They give them antacid. The antacid there is not really going, is not to stop the production of acid. It only acts as a base to buffer the acids that is secreted. So it's a temporary relief to that pain. Then we have antibiotics because of that infection by bacteria. And then proton pump inhibitor like omeprazole. We have H2 receptor blocker like those ranitidine. And then another one is bismuth subsalicylate. At times also they can give the patient sucralfate. So the role of sucralfate is not to stop the production of acid, it's just to coat the stomach lining, so that when the patient eats, the effect of that pain from the acid secretion will be less. So we teach patients when they are to take sucralfate to take it on an empty stomach at least 1 to 2 hours before eating, so that it can really work first. It can coat the stomach lining before the food comes in. Now they have a regimen to, if they want to eradicate the H. pylori especially, so they can decide to combine antibiotics with maybe proton pump inhibitor and at times bismuth subsalicylate. So they combine many medications, especially if they want to target eradicating H. pylori. Now we have lifestyle modification. So this one is centered around the patient, teaching the patient to avoid caffeine because it can worsen symptoms, avoiding smoking all along, avoiding alcohol, and avoiding spicy food if possible, reduce spicy food. And the patient that have peptic ulcer disease, since one of the causes NSAID, they should avoid anything that has to do with NSAID. Also, you are going to teach the patient that when they go for checkup, for treatment, we want to see the healthcare provider, they should let them know that they have peptic ulcer disease, so that when they are prescribing any medication for pain, they can consider other options other than use of NSAID. And we also teach them to, like for the ladies that have menstrual pain, instead of using NSAID, they can use Tylenol or other options, so that it doesn't further cause more problem on that stomach. And also part of lifestyle modification, we teach them to take care of themselves. They should not eat heavy meals. Heavy meals is going to worsen symptoms. So instead of eating 3 large meals, they can eat their meals smaller, in smaller quantity, so that it can reduce that symptom, that heaviness that they may feel. Then adequate rest. We know that stress is another one that can trigger those symptoms of peptic ulcer disease, can make the feeling worse. The last option is surgery. If any of those other methods is not able to work and the patient is feeling worse. So the first one is vagotomy. Vagotomy has to do with cutting out some part of the vagus nerve. The vagus nerve is the 10th cranial nerve that can stimulate the gastrointestinal tract to produce hydrochloric acid. So when they cut out some of these parts of the vagus nerve, it reduces that excessive stimulation of hydrochloric acid. Then pyloroplasty is another one. So this one has to do with cutting part of the pyloric sphincter, especially where the scarring is occurring. The essence is to prevent obstruction gastric applet obstruction. And then the last one is gastric resection. They could do gastrectomy. They can cut out some part of the stomach that is diseased. But in this one, when a patient goes for gastric resection or gastrectomy, you should watch out for dumping syndrome where the stomach content empty too fast into the duodenum. Now let's look at some NCLEX-style questions that will test your knowledge on peptic ulcer disease. The first question: which dietary instruction is most important for a patient with peptic ulcer disease? A. Drink a glass of milk before every meal. B. Eat large meals 3 times a day. C. Avoid caffeine, spicy food, and alcohol. D. Follow a high protein, low fiber diet. The answer would be avoid caffeine, spicy food, and alcohol. These are things that can trigger or worsen symptoms. Question 2. A patient with peptic ulcer disease is prescribed sucralfate. What should the nurse teach the patient? A. Take this medication with meals. B. Take it on an empty stomach. C. Take it with antacid for better effect. D. Take it before bedtime only. The best answer would be B. Take it on an empty stomach. We know that sucralfate is there to coat the stomach lining, so it should be taken before meal. 3. A nurse is reviewing the medication list of a patient with a history of duodenal ulcer. Which medication should be questioned? A. Ibuprofen. B. Omeprazole. C. Sucralfate. D. Clarithromycin. So the best answer will be ibuprofen. That's an NSAID, and we know that NSAID is a major cause of peptic ulcer disease. Question 4. Which of the following is the most common cause of peptic ulcer disease? A. Low fiber diet. B. Helicobacter pylori infection. C. Calcium deficiency. D. Spicy food and hunger. So the best answer will be Helicobacter pylori infection. That's the major cause of peptic ulcer disease, followed by NSAIDs. That wraps up today's topic on peptic ulcer disease. If you find this video helpful, please like, share this video, leave your comment, and subscribe for more educational videos. Thanks for watching.